Okay, it's 3 p.m. in Rio de Janeiro, 1 p.m. in New York. Hello, everyone, and thank you for joining us today on behalf of the Radiology Society of Rio de Janeiro and OCAD. I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Rower Pedersen, Dr. Guillaume Bierry, and Dr. Paulo Agnolito. This session will focus on sports imaging, and the speakers will present their cases, and at the end, we will have a Q&A session, as usual. If you have any questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. Just a quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and with that, I will kick off the session. It's my pleasure to introduce Dr. Rower Pedersen. He's a Norwegian MSK radiologist. He's head of the MSK imaging in Unilabs Radiology, Norway. He has 20 years of experience as an MSK radiologist and has an extensive experience as a lecturer at national and international courses and conferences. He's one of the founders of the Norwegian MSK Society, and his first president. He also runs the Instagram MSK Radiology reaching almost 13,000 followers. Please, Rower, share your screen.
Thank you. And thank you, Aline and Hilary, for having me to this amazing series of lectures. I'm going to focus on the medial part of the knee, a very small area. And as you can see, this is me in the snow right now. We don't have the temperatures that you may have all over the world. It's kind of freezing in Norway right now. I have a couple of small disclosures not relevant to this talk, but I'm cooperating with the Collective Minds Radiology and lecturing at the Telemedicine Academy of Barcelona. So let's talk about medial collateral ligament anatomy. I'm sure all of you know this ligament. It's very often injured. It's very often evaluated on all your MRI studies. So it's a slender, thin, black ligament along the medial side of the knee, extending from the medial condyle of the femur to quite far down on the tibia. It can be defined on axial images, and just behind it, posteriorly to that ligament, will be the posterior oblique ligament and the posterior medial capsule of the knee. I also want to draw your attention to these very small ligaments, the meniscotibial ligament and the meniscofemoral ligament, seen most often at the medial part of the knee in the midline. So they attach to the meniscus, and they can be injured as well, as we will see in a few minutes. So let's warm up. We have a lot of snow and ski-related injuries in Norway, and the next months they will be coming into our clinics and presenting findings like this. For instance, on your left side, you can see the bone marrow edema and the soft tissue edema around the knee, but you can also see that the medial collateral ligament has avulsed a small cortical fragment from the femoral condyle, displacing it just slightly. On the middle image, you can see the medial collateral ligament as continuous. You see the medial meniscus, the meniscotibial ligament, but the meniscofemoral ligament is gone. Cannot see it. Maybe some small remains here, but mainly edema, soft tissue edema between the superficial part and the medial condyle, and some bone marrow edema as well. And to the left, this is not a snow injury. This was a martial arts performer who did a high kick and had a valgus injury of the knee. And he has a bone marrow edema in the lateral condyle with a small fracture. On the medial side, there is a rupture of the MCL, the superficial part of the medial collateral ligament, and also thickening and rupture of the medial meniscofemoral ligament. So that's what kind of common cases in superficial and deep parts of the medial collateral ligament. Then I want to show you 3 cases. This first one is a 50-year-old, and it's mainly proton density fat saturated images that I've chosen to show you these injuries. We see parts of the ACL, it was intact, but the PCL, the posterior cruciate ligament, is thickened with high signal in the middle part, so it's ruptured. On the medial side, there are soft tissue edema. You can find the medial collateral ligament as continuous. There is edema between the medial collateral ligament and the medial femoral condyle, probably a rupture of the deep part, the meniscofemoral ligament. And there is bone marrow edema at the posterolateral part of the distal femur. Also, there is a peculiar finding in this area. It seems like the medial collateral ligament continues along the femur. That is not a natural anatomical structure. It wouldn't be the medial collateral ligament attaching so far proximal. No, this is the periosteum of the medial femur, which has been stripped away from the medial femur distally. We can see it even better on this next case. You have to take my word that the medial collateral ligament is intact. This is just one of the slices, and on the adjoining slices, you could find the entire medial collateral ligament. But it's stripped away from its proximal insertion together with the periosteum, and there is fluid and soft tissue edema around that part of the periosteum, and also an injury at the proximal end. Again, there is a posterior cruciate ligament rupture, quite clearly seen in the middle part. There is bone marrow edema at the posterolateral part of the femur, and we cannot see the medial meniscofemoral ligament. It's gone as well, but the meniscotibial ligament is intact. Okay, one more case. This is a case who sustained a previous injury to the ACL, and the ACL was reconstructed. So we can see the postoperative changes in the tibia. But then there was a new injury, and we found that the PCL was now ruptured as well. And on the medial side, again, the medial collateral ligament, somewhat thickened, but it's also avulsed from the medial femoral epicondyle together with the proximal periosteum at the medial part of the femur. Again, the medial meniscofemoral ligament is torn. Cannot see any bone marrow edema in that area in this case. So keep that in mind for a while. I guess you all know this injury. This is a bilateral Pellegrini stida lesion. And Pellegrini stida is the name of 2 Italian guys, I guess, but it denotes a bony protuberance or calcifications at the medial part of the distal femur. In this case, bilateral, but it could be on one side. And traditionally, we always thought of this as a chronic injury to the proximal insertion of the MCL with bony changes, scarring of the ligament. In 2009, there was a nice article in Skeletal Radiology showing a similar bony change on the distal femur, and this was in 4 cases, somewhat more proximal than the expected location of the medial collateral ligament insertion. But it looks kind of similar, just a little bit more cranial to the expected location. And in this article, they showed exactly the same as I've shown you in 3 previous cases. There was a PCL here, there was an intact medial collateral ligament, but it was stripped away from the femur along with the periosteum. And what they proposed in this article was that, well, you have this injury, there is soft tissue edema, there will be a subperiosteal hematoma beneath that stripped away portion of the periosteum, and then heterotopic ossification as a repair process leading to these changes. So that could explain some of the more proximal Pellegrini stela lesions. So I read this article in 2009. I thought it was a cool concept, and I started looking for it. And I've seen a lot of these cases, and we find them in especially ski injuries. And probably what happens is a valgus injury and a torsion in the knee. It's hard to be certain of what kind of mechanism that is the reason, but they seem to come together as a footprint like this. So the proximal MCL, it could of course be ruptured or avulsed, but sometimes with a bony fragment, but in these cases, it's avulsed in continuity with the periosteum of the distal femur. And we've also found that all of these cases has a rupture of the PCL. We've also found, not described in that article from 2009, that the deep part of the medial collateral ligament is always ruptured, the meniscofemoral ligament. And there is almost always bony edema at the posterolateral part of the femur. So it's kind of a footprint for this injury. Sometimes we see this injury first, and then we, in a way, know that there has to be a PCL injury as well. Let me talk just briefly about the deep part of the medial collateral ligament. There is a meniscotibial part, and there is a meniscofemoral part. And that meniscofemoral part can rupture in isolation. It does not, if it's ruptured in isolation, affect the knee stability, but it may give rise to pain along the medial part of the knee. And that could explain the patient's symptoms, even though every other structure is intact. And we see it in cross-country skiers, downhill skiers, probably mostly after the leg getting caught in the snow, hanging back when you continue forwards, and then there is a torsion and a valgus trauma to the knee. The meniscotibial ligament does not rupture in isolation, to the best of my knowledge, but more often together with an extensive medial collateral ligament injury or an ACL injury. If it ruptures and avulses a small bony fragment from the tibia, you could find that small fragment on an ordinary X-ray, and that would be sometimes called the reverse second fracture. If you have an avulsion of the meniscofemoral ligament, it could be called the stida fracture. This is the reverse second fracture. Maybe you can see that small part of the cortex avulsed from the tibia and bone marrow edema. And of course, these ligaments can tear or rupture at the insertion to the meniscus, either at the meniscofemoral part or the meniscotibial part. That could explain some of the findings that we may see on ordinary X-rays. For instance, that small reverse second fracture. We could, on both MRI and X-rays, see bony fragments in this location. That would be the stida fracture and avulsion of the meniscofemoral ligament. This, however, is calcific peritendinitis of the medial collateral ligament in about the same location, but more bulky and more lobulated than a small avulsion. And this would be typically at the insertion of the posterior oblique ligament. And finally, on your upper right, a bony protuberance too cranial to be a MCL injury. So this is probably a variant of the Stida pellegrini, may be related to an avulsed and stripped away periosteum from the medial collateral, from the medial femoral condyle. So I've tried to describe this peculiar footprint, which we see from time to time with PCL tear, MCL avulsion with periosteal stripping, a deep menisco medial collateral ligament tear or the meniscofemoral tear, and posterolateral bone marrow edema at the LCL origin. If we take a follow-up image of these injuries, they don't usually need any surgery on the medial side of the knee, but then after a while, the stripped periosteum will nicely oppose to the femur again and heal, sometimes just with slight signal changes. And I also shown you that the tears of the meniscofemoral ligament or the menisco, these small ligaments can tear as well. The meniscofemoral ligament in isolation, but the meniscotibial ligament usually as a part of a larger injury. And so there are several explanations for those medial knee calcifications that we may encounter. Okay, thank you.
Thank you, Roar. That was a beautiful review. By the way, fun fact, the voice of Olaf in Frozen is my cousin, Josh Gad. Okay, now it's my pleasure to introduce Dr. Guillaume Berry, who's professor of radiology and director of musculoskeletal radiology at the University Hospital Strasbourg, France, where he attended medical school and received both residency and fellowship training. He did additional residency training at Cochin Hospital in Paris and fellowship training at Harvard Medical School in Boston. He's a member of multiple French and European radiology societies, as well as the RSNA and ISS. Okay.
Thank you. Thanks for having me. Okay, let's start. Okay, excellent. So it's a real pleasure to be with you today. Where is it going? Here it is. So here are my disclosures. Let's start with a case. So it's the story of a 22-year-old bodybuilder that felt a pop in the right groin during a 300-pound squat. So an MR was performed, and I propose you to have a look on the axial PD fat set series. Okay, let's now have a look on the coronal series. Okay, so before going back to the case, let's have a quick review of the anatomy of the quadriceps. As of course you may know, there is 4 parts of the quadriceps: the vastus intermedius, just below on the level of the femoral shaft, and on the sides you have the vastus lateralis and the vastus medialis. And the more interesting part of the quadriceps is of course the rectus femoris, that is on the anterior aspect of the muscle, and it's the more vulnerable to injury, and it is indeed the most commonly injured part of the quadriceps. Probably is anatomy explained in a significant part the ratio of injury that this muscle can encounter. And let's have a quick review. At the very proximal part in the ascension of the pelvic ring, you have 2 heads The first one is a direct head directly on the anterior superior spine, and an indirect head, as you can see right here, that's running around the acetabulum to insert on the lateral aspect of the acetabulum. And as you can see, this both head are, of course, doing distally, and things going to be interesting at that level, because as you can see here, the direct head becomes kind of an anterior fascia or an anterior aponeurosis that covers the anterior aspect of the muscle, while the indirect head, as you can see here, goes within the muscle to form a central or intramuscular tendon, if you like. And this configuration goes on until the mid of the muscle, as you can see right here, when the anterior aponeurosis begins to disappear. And another structure appears at that level. It's a posterior fascia. So see, the anterior aponeurosis is replaced by a posterior fascia, as you can see right here. It goes all along until the very distal part of the muscle, where the posterior fascia form an individual tendon that going to blend with the tendon of the three other parts of the muscle. So as I told you, the rectus femoris is the most commonly injured part of the quadriceps, and within this muscle, there are areas that are more vulnerable than the others. And as you may know, the most commonly injured part of the muscle is the mid part here, as you're going to see at the level of this central tendon. The distal part is the second part that's more injured, while the proximal part is less commonly injured, and sometimes the diagnosis of this area is quite difficult to assess, because I think we're not very that familiar with the anatomy of this area. So let's have a quick look at the normal anatomy of this proximal incision of the rectus femori. Let's have a look on those axial slice. It's not showing. Okay, no problem. Let's run it. So as you can see, it's going quite a bit rapidly. You have the direct tendon right here on the spine, the anterior spine, and the indirect tendon that's inserting on the lateral aspect of the acetabulum. And you can see here, both tendons going distally and blend for a moment. Then you can see the indirect is going to move anteriorly on the anterior aspect of the muscle body to form, as we saw just before, this anterior aponeurosis. And the opposite, the indirect tendon, you see, remains on the medial aspect of the muscle, and then goes within the muscle body, as you can see right here, while the direct tendon form an obvious membrane right here. So there are two different components of the anterior tendinous anterior aspect of the muscle: the direct tendon that forms an aponeurosis, and the indirect tendon that, after a twisting motion, forms the central or intramuscular tendon. So two different configurations, and we're going to see that the pattern of injury are going to be very different depending of the structure that is injured. So let's go back to our case. So let's see the axials. Once again, we saw the direct tendon right on the iliac spine, as you can see here, and the indirect on the lateral aspect of the acetabulum. Okay, let's go now. You can see here there is fluid and eye signal area surrounding those two tendons. Once again, we nicely identify the direct tendon right here and the indirect head right here. Let's going back. You can see that at level the indirect head is still nicely visible, but we should see something here. And obviously, the direct head is not seen anymore, is not visible anymore. Let's go even further. As you can see right here, this is the indirect head that becomes, at that level, as you can see, an intramuscular or central tendon, and the aponeurosis is not seen anymore. So this is a severe MTA, so myotendinous injury at the level of the anterior aponeurosis. Just a quick reminder of what we just saw before, the normal anatomy of this area. As you can see, the eye direct head forming this intramuscular tendon, as you can see right here. But all this anterior aponeurosis, as we should normally see at the anterior aspect of the muscle, has completely disappeared right here. There's nothing left to see. So there is an obvious rupture of the direct head and several MIT of the anterior aponeurosis. So we have both component, and we're going to see that it's a major aspect of the prognosis. On the coronal MRI image, we can see an extensive edema along the quadriceps muscle, along the medial aspect, lateral aspect of the vastus medialis, and this is the landmark of those of this myotendinous injury at the aspect of the medial aspect of the rectus femoris. And when we go even backward during the slides just behind the one we saw, as you can see right here, there is an obvious interruption. There's a rupture of the direct head of the rectus femoris. So we have an obvious damage to the connective tissue, the supportive tissue, and this is so-called an high-grade MTI. And so the diagnosis is quite poor, with a return to play that is over 12 weeks. So the crucial point when you're dealing with an MTA, it's to identify an injury to the connective tissue. And this is the main prognosis factor of the return time to play. So when you're a corresponding physician, or if you are working with athletes, the main information you have to give in your report is the presence or not of an injury to the connective tissue. A quick review about the mechanism of injury of the quadriceps. You probably know that there is two types of motions for a defined muscle. The most common one is the better known motion is, of course, the concentric motion. That is a motion where the tendon shortens, so the action happens